a little bit about me is that, as I said, my name is Lana Kim, and I'm going to be a rising junior at Rice University studying integrative biosciences and health sciences. And following undergrad, I hope to pursue a MD and PH, and then eventually become a pediatrician and work closely with nonprofits and do research in the public health realm. My public health interests lie in substance use and abuse, as well as nutrition and obesity, and especially the disparities within these realms. And then a little fun fact about me is that I have had 6 dogs throughout my life, and all of them have had names that start with L. So, with Dr. Fernandez, I've been able to work on an ecological momentary assessment or family functioning study. I've actually been able to work with her on this project since roughly end of January, beginning of February, and I was lucky enough to find this program and be able to kind of continue my work with her. So the purpose of our ecological momentary assessment is to use these types of assessments to survey daily family functioning behaviors of Hispanic adolescents and their parents through a smartphone app and eventually understand how these behaviors can influence the adolescent's health. So what exactly is EMA? So whenever I came into this study, I didn't really know what this meant, so I definitely had to do my own research. And EMA is actually a type of study that is used to assess a subject's behavior and experience in real time and their natural habitats. EMA is great because it minimizes recall bias and maximizes our ecological validity. And to kind of get that real-time experience in their natural environments, EMA studies often use random time samplings and as well as technologies ranging from electronic diaries to telephone calls. And similarly, our study also uses those things, a kind of a combination of both. We use an app called Life Data, in which all participants will be asked in random times of the day, of course, times when they're awake, and they'll be asked to briefly respond to surveys sent through this app just one time per day for the duration of the study, which will be roughly 8 days. So parents and their adolescent will get different questions, but questions that kind of correspond to each other. So for example, a question a parent might be asked will be, I made my child feel better after talking about their worries with him or her. And then on the adolescent side, they may get a question such as, my parent made me feel better after talking about my worries with him or her. Another example a parent might get is, I was easy to talk to if my child wanted to talk. And then the adolescent will get, my parent was easy to talk to. So our study timeline, it's kind of broken down. I broke it down into kind of 3 sections. So we have, of course, our testing protocol, developing the research protocol, creating an introduction for our participants through Canva, something really easy for them to understand. And then we obviously had to practice our participant assent and consent procedures. And then our second step is kind of involving recruitment and onboarding participants. And as that kind of sounds, that just means recruiting participants with flyers and confirming that they're actually eligible to participate. And eligibility criteria includes them being from Hispanic/Latinx origin, and then having an adolescent between the ages of 9 and 17. And of course, the participants must consent to the study and watch our EMA video demo through Canva to kind of get an understanding of what they're going to be going through. And then lastly is we're going to be tracking and interpreting participant data. As mentioned earlier, this study will last for about 8 days, and these participants will receive questions throughout those days through the Life Data app. And eventually with that data, we want to examine changes across time and family functioning between the parent and adolescent, and assess the concordance, how they differ, how they're similar, the answers are between the parents and the adolescent, to also understand those family functioning measures. So where are we right now? So since the beginning of February, we've been kind of working on that testing protocol. And right now we are, sorry, my dog is like at the door, but right now we're waiting for compensation for the participants to get involved. And then right whenever that compensation starts, we'll be able to recruit participants. And like I said, it's only an 8-day kind of survey, so it'll be really quick, and then we'll be able to interpret data from there. So yeah, and then I've also been able to work on the sipping behavior project, kind of helping with the manuscript, helping with the introduction. So my part of the introduction is what are the risk factors for alcohol use? And through my research, through PubMed, I kind of found kind of three big categories of risk factors. So first was contextual factors, and this includes like your surroundings, your peers, your family, and of course, since our project is a lot about the family environment, I chose to write a lot about family functioning and how that can lead to use of alcohol. And then we have personal factors, which include a child's natural tendency to have delinquent or impulsive behaviors. And then lastly are behavioral factors, which are kind of like actions that adolescents do, such as these sipping behaviors, which will be the biggest part of this manuscript. So thank you. Thank you so much.
Awesome. Really nice job again. Others? This is a big group, and it's such a cool project. It's really good to hear about EMA and your exposure to that method. Do others have questions or comments?
Like, I think you did a great job. EMA is something like I'm interested, but I haven't got a chance to really look into this. So thanks for the introduction. I'm just curious. I know it's not you guys are not there yet, but I'm just curious how to like get the data from that app. Like, I'm just curious that in that process.
Mm-hmm.
Lana, do you want me to go ahead and answer?
Yeah, you can go ahead. Yeah.
Okay.
I don't
Yeah,
know.
so the Life Data app actually uploads the data from everyone's smartphone onto like a dashboard that you log into and things like that. And then you can download the data into like a Excel file or a DAT file from the dashboard online. But it's all, we use a anonymous way of surveying. So none of it has like personal identifiers or anything like that. Lana knows a little bit about the whole issue that we went through when we were trying to get a subscription to the EMA and got all of the admin involved. They were very like scared, but we convinced them otherwise.
Okay. Yeah. Thank you.
Mm-hmm.
Very cool.
Yep. Thank you.
So I have a question for Lana. So Lana, what do you think about ecological monitoring assessment in general, the whole process, how it works? Because it's not one of the most commonly used methods, and I think this looks like a great learning curve for you. And what do you think? How is it going to shape up for you in your future studies, and how is it going to help you?
Yeah, so I've never kind of heard or dealt with EMA before. Like you said, it's probably a little less used, but I think it's great in the fact that it really does test people on, right at that moment in their natural behavior because, I know that a lot of participants, they often feel like pressured or swayed to feel a certain way whenever they know they're doing an experiment like later in time, and that can kind of cause your memory to be kind of blurred, and because your memory is also easily malleable, so it can change whenever you try to recall certain things. So I think this is a great way to minimize that. Of course, there might be some challenges that we'll face whenever we actually start the EMA test, such as if people will actually do it, during the days, because unlike some other tests where it's just one quick and go big survey, this will be challenging them to do it on their time within these 8 days and really taking accountability for themselves to finish these surveys, even though they're not that long. The days can just kind of be crazy for some people. So yeah, I think that it'll be a great experience to learn and see how our respondents kind of respond and see how that goes. And I'm also pretty interested to see how the adolescents will answer as well, since that's a huge part of our study. I'm really hoping that there is no like pressure from parents or anything, which could also maybe be something to consider, which I was kind of considering. But overall, I think this would be a great experience and a great study that we have.
Excellent. It's quite impressive. The app and everything is looking really impressive. So I really wish you good luck with you and Dr. Fernandez. Good luck with recruitment and the best data set you can get for this study. Yeah, great work.
Others?
To
Sorry.
I would like to thank specifically, like, of course, Dr. Messiah and Dr. Fernandez, as well as Savannah, for all like helping me this summer, as well as like way before the summer. I just wanted to mention that. I should have mentioned that before.
You're more than welcome. I was going to say you're very lucky because Dr. Fernandez is a quickly rising star, I think, in the national space in this methodology. So look out. I think she's about ready to smash her first big national NIH award that has this methodology. So because of that, she can really become a national leader here. So you're really lucky that you're kind of in that space with her. And I do feel the whole landscape of qualitative analysis is sort of shifting too, in that rapid qualitative analysis is becoming a very keen new methodology for exactly the reasons you said. You know, it's sort of like when you're developing interventions, which is, again, is one of her areas of expertise, you kind of don't want to wait until the end and to get the feedback, because people may not remember in real time what their experiences were. And it's so important to, when you're adapting an intervention to a certain population, to be able to do that in real time and get the feedback from the participants. So I really think that this type of methodology is you're going to see it more and more frequent. That and mixed methods, mixing this qualitative type of data collection with quantitative. So this mixture of interviews with surveys, with EMR data, health outcomes data. I'm seeing that in NIH study section more and more, and it's very highly respected as an approach. It's weird. It kind of went through this evolution for a while where everybody was sort of poo-pooing qualitative analysis. It wasn't rigorous enough and so and so. And now we're seeing it's actually more important in many ways, because aggregate EHR data, EMR data gives us, yes, data on labs and what's collected in clinic and things like that, but it doesn't give the rich contextual data of a participant in all sorts of other ways. So I really think that you're going to see more and more growth in this space, and your team could be absolute leaders in, especially adolescent, that whole AYA population, and then from there thinking about risk behaviors, protective behaviors, things like that. So it's a really great opportunity.
Those were exactly my sentiments. I was trying to give a hint of imagining the impact of having this kind of an experience before you enter a graduate program, and so yeah, try to foster this and try to build upon this, what you've been doing with Dr. Fernandez. Yeah, good work.
Yeah, you know, as somebody who's sat on medical school admissions committees for years, for especially for Department of Pediatrics, seeing this type of work is something that will really help with your application too. The appreciation and talking about in your application, learning about your patients and their families and their experiences beyond just their data, their medical data, will really, really go far. Okay, anything else for anybody else?
Yeah, I just want to add, actually, it's very true what everyone was saying, uh, especially with big data, where there's a lot of data around in the world. I mean, you got data from a billion different sources coming in, including social media, EHR, and everything. But this personal experience, qualitative analysis, things like that are like the next big thing. That's the stuff that's going to customize your delivery of care, your experiences, how things interact with you and other customers and patients. And so this software that you guys are using seems really cool, very interesting. And it is actually there's also very there's growth in that field. And so a lot of institutions, for example, use RedCap for data collection. It's a widely used system. And so they've branched out to a project called MyCap, which does similar things because researchers have profound, they really want to look into this area for future projects and studies. So you guys are pretty much at the forefront of this right now. So it's very interesting.
Yeah, great point. So just keep on doing all the great work for sure. Okay, thank you. Another wonderful presentation. Luke, are you ready to roll?
Yes, I'm ready. Give me one moment to share the screen.
All right. You are good to go.
Okay. Well, first of all, this is just the title slide, but just a brief. I want to just go over to kind of the agenda that's going to happen for this presentation real quick. I want to talk about just briefly my background, who I am, and like my interests and why I'm interested in public health, as well as the paragraph that I've been working on for the sipping behaviors study on family discordance, and then also I want to talk about the ABCD open science model study that we've been using a lot for some of our studies that I was asked to go over and review, and then of course at the end, any questions and stuff and stuff like that. Sorry, I'm a bit nervous, but I'm trying my best. But my name is Luke Alejandro. I'm a rising junior from Rice University. I'm majoring in health sciences with minors in neuroscience and medical humanities. I've been really interested in Hispanic health disparities, especially those ones concerning like nutrition and preventative health, especially though the one I'm really interested in is like rural health. I grew up in a really small town with maybe about 300 people. Because of that, I think it's really important to just focus on rural health, just a variety of problems concerning like being away from a lot more resources in bigger cities. And just as a fun thing, I'm like just a little fun fact about me. I'm a huge Star Wars fan. My parents they named me after both Luke from the Bible as well as Luke Skywalker from Star Wars, and it's always a fun thing. I want to go ahead and just talk about the what family discordance is and to go a broad overview of it. Basically, family discordance is when families disagree or inconsistent in how they view the dynamics of the family. In other words, when there are different views among the family from about a variety of things. This usually happens between the parents and children during early to middle adolescence and their teen to tween years. And what's surprising is this is very common in lower socioeconomic households. And there are many factors when it comes to discordance in terms of like why it happens and where it stems from. And when I was doing a lot of research, I was going through and I was trying to find things specifically on the relationship with alcohol and sipping behaviors because that was relevant towards the study. But I was having trouble finding a lot of information about that, so I went to other avenues and other studies, such as things like through sleeping behaviors, through the other family functioning things, through a variety of other problems, and it stems from like different parental monitoring. structures, usually when they either under monitor their children or over monitor them, as well as a lot of pressure from the parents onto their kids for a variety of factors, expectations. And then the biggest thing of consistency is always just a general lack of trust or communication, whereas where a lot of the problems stem from when kids are not quite willing to talk to the parents about stuff due to just being worried about being judged or being worried about not meeting the expectations of the parents. And so there's a variety of unhealthy home environmental factors are commonly associated with low family functionings and these discordances. And wait, one second. There. And so they're commonly associated with that, and like that includes a variety of things such as like lower family functioning discordances associated with like eating disorders, or not having proper nutrition, engaging in alcohol consumptions, performance in school, sleep quality. A variety of them stem from these discordances, and it's kind of ironic because they stem from each other. As more discordances happen between the family, these things often increase and continue more, kind of creating an unhealthy cycle, if you will. And I want to talk about really why discordance in family functioning is like really relevant, because the one like biggest consistency that I saw when it comes to the studies is that discordance is not always properly measured due to a variety of factors, especially because of like expectations among the family. For example, like there are some studies that they were talking like when they were interviewing the family. They were all together, and then they interviewed them separately, and they had very different responses. This is likely due to a variety of things, due to like the kids maybe not wanting to say things in front of the parents, like I said earlier, due to expectations, due to a variety of factors, and even the other way around, due to parents maybe not wanting to like admit like vulnerability in front of their kids, things such as that, which is why in our study that we're doing in terms of family functioning, that's why it's critical to have like an avenue for both the adolescents and the adults to express their opinions separate from each other. That way you can account for that factor in order to get accurate information among both the children and the adults. That way there's no judgment from each other, if you will, if that's there among the family. And I want to go ahead and talk about the ABCD study, which is a study that we've been using for some information for the family functioning study. It's the Adolescent Brain Cognitive Development Study. The ABCD study is a great acronym. It's the largest long-term study of brain development and child health in the U.S. At the moment, there's almost 12,000 children that are participating in the study as of last time that it was updated. And it measures how a variety of like childhood experiences interact with each other and how they affect brain development and a variety of outcomes, if you will. And this is a variety of things from like different friend dynamics, things such as video games or different parenting styles, and then how they affect different outcomes later in life. Everything from just education, grades in school, how the child is feeling in terms of, I'm sorry, wrong sharing thing. How the child feels in terms of variety of things. The study design is basically the kids, they come onto the study around 9 to 10 years old. The parents and the kids, they volunteer, and it uses a variety of neurological assessments like brain imaging things, and then as well as structural assessments like cognitive studies, and they measure a variety of things such as the cognition, parental relationship, mental health, physical health, a variety of other factors throughout the variety of years up until they're about 19 to 20, until they become young adults. And then the data is shared annually, like for use for a variety of studies. And this is a very, very important, it's a very, very big study. And the reason why it's so important is because it's like I said, it's the largest study of this caliber, and having this many children and studying them throughout their entire life in terms of a variety of things it really helps answer a variety of questions on both brain behaviors and adolescence, which like gives us context to a variety of family functioning issues and childhood development things. So studies relevant for here, as well as studies relevant in a variety of other fields, especially in neuroscience, especially due to the neurological developments and studies that are happening there. And the data can be used to implement like preventative health practices by like informing parents about these issues and informing the public about why their children may not be like as communicative or trusting of them, and they can work on fixing that, and allowing also children to get like the proper resources that they need in order like just to improve overall outcomes and overall childhood health later on. Thank you so much. I want to like say real quick that I really appreciate like this opportunity this summer. It's like really helped me personally like kind of narrow down my focus in terms of public health. I was like had a whole bunch of interest at the beginning, but now I think I've narrowed it down a lot more to like preventative and rural health now, and I just kind of like solidified my focus and that I want to do research in this in the future. And thank you so much.
Thank you. That was a great presentation. Questions, comments from the audience?
No questions, but just a comment. Like, so have you started working on the ABCD project or not yet? Or are you just trying to find out hypotheses and ways to work on it?
I've been Dr. Fernandez asked me to kind of look over the study a little bit because it's kind of and like summarize it because it's in a very important part of the study that we're doing in terms of family functioning.
Yeah, because I got to know about this ABCD study through Dr. Fernandez, and I'm working on a project with her on this, and it's a treasure chest. So if you plan to go on to pursue any graduate programs in public health, then this might be, you know, your bread and butter for next few years. So try to capitalize on this. Yeah.
Yeah, I really think so. When she told me about it, I was really fascinated just because I originally wanted to like I was originally like really in between doing things in public health or doing something in neuroscience later on. I eventually said decided to do more in public health because I care about that a lot more. But having more of kind of a neuroscience back and psychology kind of part of it, I think just really like implements my interests together, which is like I really like that personally.
Yeah, it's like it was made for you, for sure, and all your two big interests.
And I'll just make a quick comment about the ABCD study. I also really think that it has, it's mainly like focused on neuroimaging and things like that. So a lot of the social and behavioral variables that they are still collecting data on are really untapped. And so if you're interested in that, it has a lot of demographic data. So you can kind of go into like social determinants of health and things like that. And so if you're at a different institution, obviously, like I think as a student, you may not be able to get access like personally, but I would contact like maybe a faculty member and see if they can get access to the data so you can, you know, work with the data and things like that. And on ease of access, I would consider this like pretty easy to access and get permission to use the data because I know that other data sets are a little bit harder. They're a little bit more, you know, they're a little bit more stingy, I guess, with the data release. But the ABCD data is like relatively very easy to get access to. And so if you're like at Rice or RGV or whatever, I would just find a faculty and see if they can get access to the data as well.
That's good to know. I've actually, NIH has released a couple of notices of interest for funding for this data set. I think for exactly probably the reasons you all are talking about, that they really do want people in there and analyzing the data in creative ways. On study section, I've seen several come through also using the data set. So here's a perfect example of sort of talking about what we were yesterday, that combination of creativity and science, where you can think about, given from what sounds like a really rich data set, how can you combine variables to answer new and innovative research questions? And Luke, I really appreciate your interest in your personal dedication to rural health. That's another disparate population that the NIH is very interested in for all the reasons that you said. So I would encourage you to keep pursuing that path. And you have the street creds. You grew up in a small rural town, so you've got such a great story to tell. Whoever you work with, and that goes far with whoever your patient population, your participant population, whoever it is that you're working with, whether it's in research and medicine, clinical care. So I really appreciate that, and that need is not going to go away anytime soon, especially in a state like Texas. So I think you're doing all the right things in terms of starting to narrow down your focus and really think about where you want to go with your work. So that's awesome.
Thank you. Thank you.
Okay, anybody else? All right, great job again. All right, our closer is Tiffany, right? And that's it. So take it away, Miss Tiffany.
Oh, hello. Let me just present this. My name is Tiffany. I'm sorry again for joining a couple minutes late, but so the title of my project is Understanding Trends in Mortality of Periviable Births. And I was mentored this summer by Dr. Patel and Lola, who is currently a PhD student at the center. And so a little bit about me. My name is Tiffany, and I'm currently an undergraduate at Rice, and I'm studying biosciences, as well as minoring in Asian studies. I'm specifically interested in pursuing an MD and PH, and hopefully addressing environmental disparities of health through my research. I'm from upstate New York originally, so I really do enjoy the outdoors, and I think like being in the environment, I think kind of first kind of sparked my interest in really analyzing specifically like the environments, as well as kind of looking at it from a public health approach through my interest in medicine. And so for a brief background about my project, so 0.4 to 0.5% of all births occur at or before 27 weeks of gestation. And so despite the small percentage, this actually accounts for over 40% of infant deaths, kind of underscoring really the salience of kind of advancing, improvements in periviable care for infants born at these ages. And so fittingly, there have been a lot of advances in periviable care that have really greatly improved the survival of these infants. However, there still remains discrepancies in our analysis of survival of periviable infants that influence our current understanding of how periviable survival has changed over time. And so our first objective was to define the external validity of periviable survival, with the main limitation of current methods being a lack of, generalizability or like external validity. So for instance, a lot of current, studies may employ indirect methods to assess mortality, like maybe deriving data from like NICU admission, as opposed to, just like looking at death certificates overall. Or some also may exclude periviable deaths within the first 24 hours, for example. So having these kind of, like non-uniform methods to assess mortality kind of, causes us to want to, really define the external validity. And so secondly, a lot of current studies are region or hospital network specific. And so thus, our study is the first to utilize CDC Wonder data to assess the external validity of periviable survival. And why we're specifically using CDC Wonder data is because it's the most comprehensive database that reports the number of births and deaths nationally from birth and death certificates collected by like the Vital Statistics Cooperative Program. And so our second objective was to assess the influence of race, ethnicity on peri-viable survival. And, why is assessing the social determinants of health important in this context? And this is because health disparities can influence peri-viable survival in a lot of ways. Two examples are geographical location and cultural and linguistic factors, which can, cause, inaccessibility to specialized care that is needed in a lot of these instances. In a lot of these instances, or even, maybe like language barriers that influence communication that can cause, lack of adherence for patients. And additionally, we also wanted to kind of look at changes in peri-viable survival as a function of timing of death and cause of death, which are two kind of areas that are currently poorly defined. And so our main method, which I alluded to before, was to utilize the CDC Wonder database. Specifically, we're including all children who died within the US nationally between 2011 and 2020. And we're specifically looking at infants at the ages of 22, 23, and 24 weeks, which is at the cusp of viability. We calculated the age-specific mortality rates for all the specific variables that you'll see on the upcoming slides, and also performed non-parametric trend analysis for variables reported across time. And so this is our first table, which kind of highlights some of the maternal infant characteristics that we were kind of interested in understanding further. Highlighted in the yellow boxes are, I think, just a couple interesting pieces of data just to call out. So the majority of infants who died within, that were 22, 23, and 24 weeks had mothers that were between 20 and 34 years old. The majority of mothers were also non-Hispanic whites, and the vast majority were classified as, which is less than 1,500 grams. So this second table kind of highlights the gestational age-specific mortality rate as a function of, the gestational age of the infant. So you can see that the gestational age-specific mortality rate decreases as the gestational age increases, which is in line with what a lot of previous data has shown. So this table highlights trends in mortality rate of peri-viable preterm infants by gestational age and also by race and ethnicity. And what I think is interesting to highlight is, as you can see for the race and ethnicity section, non-Hispanic Blacks have the lowest average mortality rate compared to non-Hispanic whites, Hispanics, and non-Hispanic others, and their trend p-value is also like less significant compared to some of the other races and ethnicities. And this is a table kind of highlighting the trends in time of death. And you can just looking at the combined 22 to 24 weeks, you can see that the gestational age-specific mortality rate is much higher for death less than 24 hours, which is quite interesting, given that I kind of mentioned before that there have been previous studies that kind of have, just excluded data from within 24 hours altogether. And you can see that same trend for 7 to 27 days and 28 to 364 days, that the gestational age-specific mortality rate is dramatically lower compared to when the infant dies within less than 24 hours. And so finally, we wanted to look at the top 10 causes of death among peri-viable infants. And, overall for 22, 23, and 24 weeks, extreme immaturity was, like the the common one. And highlighted in the yellow boxes are some causes of death that were unique to that were uniquely within the top 10 for infants that died within 24 weeks, which is quite interesting. Quite interesting, given that like the mortality rate for 24 weeks is dramatically lower than 22 and 23 weeks. And so overall, our first conclusion was that we were able to confirm overall decreasing trends in periviable preterm infants, which matches, a lot of previous data. And our second conclusion was that we found that non-Hispanic Blacks have the lowest average mortality, gestational age-specific rates compared to other race and ethnicity groups. And this is, I think, an interesting conclusion, given that we have a lot of robust data that shows that, ethnic disparities do contribute to peri-viable survival. And so we wanted to kind of ask further, like, why is that the case? And so we kind of hypothesized that our trend analysis right now encompasses a national perspective. However, social, economic, political, and health contexts do vary significantly on a state level. And second, kind of to what was Dr. Messiah was kind of talking about like earlier, because we're kind of analyzing aggregate data, there is still, a lack of nuance that means that we won't be able to, like fully understand how these social, determinants are influencing mortality. And so that kind of concludes my presentation, and I just really want to thank the Summer Scholars Program for, like making this opportunity possible, as well as all of the really great mentorship and guidance that I received this summer, specifically like Dr. Patel and Lola, who, like helped me so much on this project and, really inspired my interest in continuing my work in public health in the future.
Amazing. Great job. I mean, really, really interesting findings. Great job, Dr. Patel, Lola. Lola's been amazing piece. I feel like she's one of our center mentor team too, for sure. And this is evidence of that. Questions, comments from the audience? I know probably a few of you have some interesting questions.
Yeah, I have a question. First of all, great job. That was a really great presentation. Really presented like the problem really well and the results and things like that. I think it's less of more of a comment, less of a question. I think it'd be interesting to look, and I know Dr. Patel can also look at this, to look at like the crosstab between the age and race variable, because that age variable is quite large, like relatively large. And it was interesting to me to see that non-Hispanic whites have like that higher number, but the, like Hispanic and Black moms often tend to be younger. So I wonder if like those numbers are maybe off because of like that age variable. So it'd be interesting to look at a crosstab of those two variables.
Oh, thank you. Yeah, that's very helpful.
Yeah, and I'll add to this. So this made us think a lot because there's so much existing literature that always tells you that non-Hispanic Blacks are disproportionately affected in terms of periviable mortality, and so this did not make sense when it came out. But then we went into the literature, and Dr. Russ Kirby and Dr. Messiah, you probably know him. He's from University of South Florida. He has actually published a paper because the CDC Wonder study has been published, I think, 10, 12 years ago using a previous data set, and they found the same thing. And they call this a convergence. It's called a black-white disparity convergence when it comes to mortality studies. Sorry for the wind noise. But then the reasons behind this is because CDC Wonder comprises of statewide data sets from all over the country, and all these states have different ways of reporting the deaths. And there has been a historic pattern of non-Hispanic Blacks reporting lesser number of mortalities compared to other race ethnicities, and that is one of the major reasons that we find this convergence. So while it's not normal, it's seen quite often in several studies, and that's why they always recommend looking at the social determinants perspective. And I think running a cross step by age and race, I think would be a good, nice next step moving forward, Tiffany. So yeah, we really appreciate that feedback, Dr. Fernandez. Yeah.
Yeah, and I mean, I think that's the thing about measurement, right? Some of these like underrepresented populations, there's like a generalization made about these populations, and the reason that we see like a lot of negative maternal health outcomes in Black moms is because they're treated differently at hospitals and things like that, and their data is reported like differently, maybe unconsciously, but that's what happens with when they don't feel like they have a voice, and don't have advocates in hospitals and things like that. They may not get like medications, and so the I mean, aggregate data is like really great, but it like kind of points to some of these like questions that are left unanswered when we do like health services and things like that, especially for minority populations. So yeah, really great job.
Yeah, I agree with Dr. Fernandez. I was just wondering if we have like mother's characteristics, as you said, like social determinant health. I think that would be really interesting to find out why we have like higher, like lower mortality for non-Hispanic Black. I think that will be very interesting discussing point. But again, great job. I think the presentation is very impressive. Like I can like imagine like you finish this in the summer, which is great. That's a lot of work. So applaud to that.
So I have to add on to this. So Tiffany is easily one of the most efficient students that I have worked with in terms of summer scholar program. Within 2.5 months, we have a manuscript pretty much ready to submit on this project. So should we give this like Tiffany do this as a next step, and she would have it ready by the next day morning. So just I mean we have had a very impressive cohort of summer scholars this year, and I've seen so much science all around yesterday and today, which is so impressive. So congratulations to Tiffany and congratulations to everyone. It's and yeah, Lola just said Tiffany has been amazing. So Lola is our doctoral student, and she also works at the center. And to all of you who don't know Lola, she has mentored our summer scholars in the past as well, Sneha, and she works closely with me on several birth defects projects. And I think it was a breeze to work with Tiffany. I think learning the instructions, implementing those instructions, and also making a scientific rationale for everything you do, and not just following instructions step by step, but also putting in your own insights about what's going on, is very, very important. And so I would like to congratulate her on completing this project, and I look forward to working with her. We have already decided that we'll continue on other projects even after the program. Yeah.
Yeah, no, but thank you so much. I think just like the program in general has just been really supportive of, like my interests. I think like it's kind of sometimes like academia can kind of have like this kind of, you know, that's kind of known sometimes for not being like sometimes like the most healthy environment, but I think like kind of like the steps that the program has made to like ensure that like it's like just like welcoming to everyone, and like especially me, has really, like motivated me to like continue working on these projects further.
Yeah, and just a fun fact about this project, Dr. Parth Bhatt, the name you see here, the third one in the bullet list, he was a junior to me in my medical school 18, 19 years ago back in India. And then all of a sudden he texts me looking at my publication. We were just out of touch for like 10, 12 years. And he's an assistant professor and a practicing pediatrician at West Virginia University. And he was like, I have this idea in mind, and how about we turn this into a project? And right at that time, Tiffany joined us. And I'm like, yeah, I have the right workforce. I have the smart people that can make this happen. So it all worked out. And then in less than 3 months, as I said, everything is accomplished, and we are now ready to draft out the final version. So yeah, always one advice or a suggestion or a guidance piece, what I would say is to keep your collaborations going on always, even after you finish something, even after you graduate, even after you complete your program. Make sure you stay in touch with people you have worked with, because you never know what opportunities may arise in future. So yeah, but excellent work, Tiffany, and everyone else. Yeah.
Others, comments?
Sarah, if you just let me make one last comment. I'm missing on a, but my summer scholars this summer were really great. I am amazed by like their potential, because I was nowhere near their level when I was an undergrad. I think my priorities lied in like different places. But they are so amazing, and I can't wait to see what they do. MD, MBH degrees, and going out into, you know, the world and servicing the people that they are trying to service is, I'm really, and I think I get this from Dr. Messiah. Dr. Messiah is a great mentor, and her love for mentorship is very contagious. So I'm just happy to be a part of the process. So I'm very excited. I was very, you know, lucky to have my summer scholars this summer. So thanks, guys.
Yeah, and my priorities 20 years ago in undergrads was what's the next movie coming in this weekend, and what's the next PlayStation 2 game that's coming out. So you are also driven, and I would like to thank Dr. Messiah for this whole platform. The whole platform is so I mean it's so well designed. I mean, you all getting to shape up your trajectories in your careers, you all getting to meet the right people who are working in different areas, and you're all getting so well set, like all geared up for your graduate schools and graduate programs so early in your careers. So yeah, thanks to Dr. Messiah and everyone who has been part of this program. Yeah.
Oh, these are great comments, and I'll come in and comment on both of you and the whole program in a second. But I wanted to go back to Tiffany's project in particular, and some comments that I have. I find the findings fascinating, for obvious reasons, even beyond the methodological maybe limitations or nuances of the data. It is exactly what Tiffany says. This is where we need that social determinant of health data. Have any of you heard of or studied yet what's called the Hispanic health paradox? So I know Dr. Fernandez knows a lot about this too. There has been some fascinating data about the protective effect of being a Latina, in terms of birth outcomes. And and they associate that to social support networks. Now that has there's been more nuanced analyses there that show, again, when you start to disaggregate, stratify by country origin of birth, born in the US, not born in the US, some of that falls apart. However, it gets exactly at that point of what is it that potentially is there beyond maybe genetics that makes pregnancies and birth outcomes more viable in certain race and ethnic groups versus others. So early in my career, actually my K award was all focused on an African American birth cohort in Miami, where half of the cohort had been exposed to crack cocaine during pregnancy. And we were my whole project was looking at cardiometabolic, cardiac outcomes as these children turned 18, 19, as they were aging into adulthood, because there had been literature showing that exposure to cocaine in particular had some very, very serious cardiac impacts on the children at a relatively young age. We did not find that at all. And we were at the same point you are, really starting to think about, like, what the heck is going on here? Like, what is it about this cohort that seems to be so robust? And we talked and we talked and we talked about it, and it's almost like these babies make it past a point, and it's like survival of the fittest. Like there was just no other way to explain it. And in fact, in many ways, the control group had worse health outcomes than those exposed to the substances during pregnancy. But I find this so interesting, given that our infant mortality rates are so high in African American communities, and actually getting worse in some parts of the country, along with maternal mortality. So I really wonder why we're seeing that. But I think your discussion in your paper could talk about this, the Hispanic health paradox as a jump off for, like, you've seen this in other populations. Why are you seeing that here? And is it somehow non-Hispanic Black women, I don't know, or have more viable pregnancies, but then, they carry it to a certain point, but then they're more they have, this is another big struggle we've had in public health, is the low birth weight disparities. By far, non-Hispanic Black women have the highest prevalence of low birth weight babies too. So what is it? Why is it they can keep a pregnancy viable, but then there's long-term residual negative impacts from this. So yes, prenatal care for sure is a part of all of this picture. Absolutely, Dr. Fernandez. But there's so many other things too. Thinking about, I know in Miami, the neighborhoods that a lot of these women were living in, that 24/7 exposure to stress, to crime, to blight, to unemployment, to poor medical care, to low education, unemployment. It just goes on and on and on and on and on. And so you'll hear from a lot of Black women in these communities just the stress, just this chronic stress. It's not acute stress, it's chronic. And so thinking about a pregnancy is 9 months, and every single day of that pregnancy, there's some exposure to stress. What is that? What is that doing to the pregnancy overall, the outcomes overall? So I think there's so many interesting points you could bring up in the discussion, and I hope you aim really high with this paper in terms of maternal impact factor, because it's such interesting data, and it's so on point for what is going on in the maternal child health world right now in this country, and the struggles we are really having with closing these disparity gaps. And we can't be satisfied with just raw birth outcome, pregnancy outcome data. There's got to be more context to it, to find out, again, what modifiable risk factors are out there that we could target for interventions eventually. Public health interventions, OBGYN interventions, a combination of the two that can help get these rates to where we want them to be. And obviously the outcomes to be better and more equitable. So anyway, those are my comments on the project. I think it's just awesome. Go ahead, Dr. Patel.
These are very, very insightful comments, and these are. I hope you took notes of these, Tiffany, as Dr. Messiah said, and Dr. Fernandez said. And yeah, we'll be happy to work with you, Dr. Messiah, and because we are working on the discussion section right now, and we do feel like it needs a little bit of an enhancement and things like that. So we'll touch base with you offline on this. Yeah.
Yeah, so I'd be happy to support it in any way possible. I think it's really, really important work. The thing that's nice is in neonatology, the scientific advancements we've had just in the past 20 years, these babies survive now. I mean, 500 grammars in NICUs, the top NICUs in the country, they're fine. I mean, even 20 years ago, that was just not even a thought. NICU, it's just neonatal science is just incredible, the advancements we have had. And a lot of these little guys really they go on to be just fine. I know lots of them now as kids. One of my primary K mentor was a neonatologist, and Jackson had one of the busiest NICUs in the country. And so they were at the forefront of the science of survivorship of these tiny, tiny, less than 24 weekers. And a lot of them, they all come back, because we follow them up until they're into emerging adulthood, and they do great. They have, most of them have very, very little negative health outcomes because they're so well taken care of early on. And a lot of that has to do with, there was this, you probably heard of kangaroo care was another big sort of innovation in NICUs too, about these babies are obviously in incubators for up to a year or more in some cases, and having mom and dad come in and do skin to skin contact was one of the best possible exposures for survival as an outcome too. So really nothing super breakthrough science there, right? It's just really interesting how that was all found out. So kangaroo care may be something else, Tiffany, just for fun for you to look into for your own career. And then I will absolutely echo my center faculty's sentiments. And I cannot take all the credit for Summer Scholars. I will tell you whose sort of brainchild this was, Sunil. Sunil really helped develop this program along with the center admin and management staff. I was just there kind of supporting. They do a lot of the heavy lift on this program. So I can't take credit. I think it was actually Sunil's brainchild. So it's a pleasure to really support it. And I agree. I feel like every summer has been just another level up. And so you have set the bar really high for whoever comes next summer. And I think to Dr. Patel's point, Nimish is a perfect example. It was such a pleasure to write a beautiful long letter to Yale about every reason she should be in their graduate program. So, and it was easy to do because of all of her applied experience. I didn't need to kind of fluffernutter it, and make stuff up. So I know that admissions committee was just like, oh, she's a slam dunk. Look at this. I mean, she's already doing what people are doing this work in PhD programs, you guys. So the fact that you're doing it in an undergrad level, it will really, really make a difference. And I think it's pretty easy to distinguish letters of recommendation from people that have actually worked with you versus just very surface letters. And having those deep, rich letters, that's what gets you over the hump. And it's just like, yeah, this is the type of person we want in the program. So I really, really applaud all of you. The work has just been all of you. And again, the presentations today, it's so refreshing. All of them, all of you are really, really articulate and excellent presenters too, which is a skill set you'd be shocked, even at the faculty level. It's not a given. It is not a given. So give yourself some credit for that too, because you will have to present. Luke, I know you said you were nervous. I know you struggled with that all summer, but you're a natural. you need to give yourself a pat on the back. You're really, really good. And so just go with it. Give yourself a pat on the back that you've already kind of got that skill going. Just keep perfecting it. I'll tell you, even I think I've told all of you that throughout the summer that I still practice for big talks. Still to this day, I still get nervous. And when it's depending on the audience, I think it's a good thing to be nervous because you care. You really care about what you're presenting to people. You're passionate about it. So that's always think about it as a good thing, is you're committed to what you're presenting. So I don't think there's ever perfection either when it comes to presenting. So you can always practice and make it better. So that just goes with the turf. I think if you're going to go into academia or even medicine, people are going to ask you to come talk on things and give presentations. So it's definitely not one of my favorite things to do by any stretch. But I do it because I realize how important it is for people to hear the science that we're doing, the center's doing, and so on. So just remember that at the end of the day. Okay, any final comments? All right. Well, you all know where to find all of us. I think one of the special parts about this program is it really doesn't end today. It's just beginning in many ways, like people said. And we're not going anywhere. You know where you can find all of us, our emails and so on. So many of these projects will continue on throughout the whole year, and we encourage that. So anything you need from me, you guys all know, feel free to reach out whenever. Okay, and on that note, enjoy the rest of your summer. Hope you get a little bit of time to enjoy the summer before classes kick in again. It's kind of crazy to think it's just a few weeks away, but. And for those of you traveling, Namisha, safe travels to the Northeast. Hopefully it's a little cooler. Enjoy fall, like a real fall, New England fall. All right, everybody, take care. Bye-bye.
Thank you. Bye, everyone.
Bye-bye. Thank you.